I'm talking today about integrating pharmacists into your practice roles, irregardless of where they live and how they perform in your community. This is not a discussion that's eliminating any other team members. We are an augmentation of anybody's practice site. So whether you have, we work with the registered dietitians, we work with other CDEs, physicians, LPNs. So I don't want you to think just, I will be all about rah-rah pharmacy. So to give you a little bit about my background, prior to coming to running the Illinois Patient Self-Management Program, I had 17 years of Medicaid. I have a master's in managed care and epidemiology on top of my pharmacy degree. They call us pharmacoepidemiologists. Nobody knows what that is, and Penn State is the only college that actually has a full-blown program in that arena. And I'm, okay. So we're going to talk about the roles and contributions, the evidence examining those outcomes with pharmacists and diabetes care teams, and actual examples of some of those successful models. A little bit about where I started. After leaving Medicaid, because we put two, Illinois governors in jail, so I had enough. They gave me shingles, the stress of it all, and I took that as a guide to go out into the private world, and I was working with some groups on contractual basis, and the Asheville Project started. And having been someone that did a lot of data crunching and claims analysis, the Illinois arena, the Midwest Business Group on Health, had the opportunity to become part of the 10-City Challenge. And you never burn bridges in this world, because the CEO of the Midwest Business Group on Health actually worked with me when I was with government. He was on my DUR committee. And so he talked me out of semi-retirement and said, we need you to come on board and help us lead in this process. So we started small within Illinois, and now we've gone national. I am blessed with two very forward-thinking employers in particular who want this program at their work sites across the country, so we are growing with them. We also have the city of Chicago, and that offers its own challenges because it's Illinois and state politics. This is just quick. I'm not going to read everything. This is so you can go home and read what we are, and if you need to replicate this in your own backyards, I'm happy to extend this, because we have people like me in every state, and there are pharmacy associations that are collaborating with insurance companies and business coalitions. We have over 750 patients right now. We're growing. I have 50 very active diabetes pharmacist coaches. We have a clinical faculty that has 7 representatives. We have 7 schools of pharmacy in the Illinois area. And so we pull from that expertise so that we replicate the American Diabetes Association standards of having an overseeing group. We also have lay people that are part of our program, and each of our plant sites has a person, an employee that serves on that committee, so that we get constant feedback about how they feel about what we're doing with their program. We also train pharmacists in cardiovascular health, along with the diabetes program. APHA Foundation has a certificate training program. The Pittsburgh group has a great training program, and the Pennsylvania State has a great online training program. In our program, we require, to get your clinical boots back on and dust off the dust if you've been hiding behind a CRT, that you have 8 hours of live physical assessment. So they don't see any of our patients until I've seen them practice on each other in a live setting. I'm non-denominational, so I don't care where you work and who you work for. I like to put together pharmacy networks and the best of the best so that we can go out there and meet the needs that you all have. Our goal is to get them all credentialed. It takes 1,000 hours to sit for your CDE and 500 hours for your BCADM. And so the goal is to get everybody credentialed. So again, our program is completely based on the Asheville Project, which is the APHA Health Map RX model. And it's about point of care with the patient, physician, and pharmacist. And we work currently with self-insured employers in a value-based benefit plan. So our patients are getting waived copays, and they're getting face-to-face pharmacist coaches. Our two major employers that have gone nationwide do not limit us. They recognize that in chronic disease management or health management, people recidivate. You're going along fine, and then your daughter gets married, and you eat half of the wedding cake that was left over. And so you need constant hand-holding and a support and a safety net. APHA, we work conglomerately with APHA Foundation. They have taken on the investment of showing pharmacist-driven work in diabetes care and chronic disease management, and this is just a little map of how they've reached out into the community with industry support and the National Business Group on Health support. So we're working collaboratively outside of our silos to bring this forward. Pharmacist education has changed. Many remember the movie from the old days where the one guy catches the pharmacist who's been drinking too much from, doing the wrong prescription. We're far from that. We mostly, we're really much more like medical school. So when you decide you're going to go pre-pharmacy or pre-nursing or pre-med, those first 4 years, everybody's kind of learning the same basic biology and chemistry, and then on average, most of the students that are coming in, we don't have 1-4 programs anymore. I was a 1-5. There are 1-6s, they're going away because most students are coming in with a bachelor's in something before they go on and get their graduate degree in pharmacy. So it's really 8 years. So they have a biology degree, they have a chem degree, we've had, right now I've had 4 students in the last year that were registered dietitians first and then went on and became pharmacists. So that is like, to me, in diabetes education, that's a wonderful combination for them. Here's the explicit breakdown of our education. We have obviously more than one semester of pharmacology, and it's everything is affiliated all for the last 4 years. We have a lot of immunology, we have a lot of pharmacodynamics, and with all the new technology, think about all the new medical technology that's out there, pharmacogenomics, biosimilars. So that's expanded what we are learning in the pharmacy world. So when these kids graduate, they are at the same level and deserving so of the PharmD. The other thing is, in order to get more patient-oriented, we have professional residencies and fellowships. I did a professional residency with the Indian Health Service. They shipped me off to Alaska. They embedded me right into the process. I was right alongside with my family practice doctor for the entire year I was there, and delivered babies and held sutures and did everything that anybody that could spell medical did in the Indian Health Service. And that's kind of where we are in some of the underserved areas of the United States. So what I think pharmacists are best qualified for doing is we can multitask. And I think we're really good at communicating with multiple levels of people in their literacy. We do a lot with health literacy. That's more being integrated into our curriculum now, but postgraduately, I spend probably once a quarter program on talking about how do we have the baby boomers understand how to take their medications? How do we take all this jargon and make it so that they can be more adherent on their medication, and we optimize medication use? So the focus is really, compliance and adherence is kind of a hard word for patients, but if you want, say, I want to help you take your medications better and get the most bang out of your bucks, you know, that's what we're here for. So the other thing I want to make clear is our diabetes patients in our Illinois pharmacy network, our pharmacists are not, if all you are is a dispensing pharmacist and you're hiding away in the world in your cave and the rest of the world is going on into the astronauts of pharmacists, those aren't the pharmacists seeing your patients. It's advanced practice pharmacists, and we invest a lot of education into that. They've invested a lot in their own. They're graduating with those credentials, and then we enhance those credentials. We are qualified and licensed to do those advanced practice diabetes education training. I'm very involved, and most pharmacists involved in diabetes is involved in the ADA, the American Diabetes Association, the American Association of Diabetes Educators. We're all collectively working in and raising the bar on that educational process. This chart is very important to show how the distribution of the primary care providers are in the United States. You can see in the light blue is the total amount of primary care providers by physicians, pharmacists, nurse practitioners, and physician assistants. Then the darker blue shows the rural areas. We always accept the fact that the rural areas have less providers, but then the important one here is to look at the health provider shortage areas. That's the HPSA. That's the government's gone in and said, you know, for instance, Southside Chicago. You have all in the north and all in the suburbs, there's all sorts of caregivers that can be there. But on the south side, we don't have grocery stores, we don't have doctor's offices, we don't have pharmacies, it's barren. And so one of the focuses of the pharmacy profession is filling in that gap. My focus as a professional helping train the pharmacists of the future is to take this group right here and make sure they're all practicing at the top of their license and becoming advanced pharmacists. And so that they can plug into that backyard and provide some very much needed patient care. And these are the areas where we move forward into those areas. Everybody's talked about the aging population. I'm the end of the baby boomers, and I have all my brothers to take care of, and so that's going to be part of that population that we don't have enough providers for. And pharmaceuticals have become complicated for good reasons. I think pharmacogenomics is really going to open up a place for pairing the right medications with the right patients, and that will help our formulary development. Let's go on to why pharmacists. Again, even though we have a preliminary group of PBMs providing prescriptions through the mail order, pharmacists are still talking to the patients 12 to 15 times a year. And the primary care providers, the nurse practitioners may only get them in for 3 to 4 times a year, if we're lucky. Because of that frequency and because they come to the stores to buy all their other over-the-counter medical products and so forth, we do have an opportunity to create access, a greater access. The national studies show that we were able to reduce treatment costs and improve outcomes. One of the things I want to bring about here and in our own study, I just finished our 6-year longitudinal study. After we started seeing patients for their diabetes at the work sites, they saw they went back to their physicians and increased 50%. Some of the patients that entered our program didn't even have a primary care physician, didn't establish themselves with a family practice doctor, and had been walking around for 15 to 20 years with diabetes and been using emergency rooms and prompt care. And the other nice thing is they go to their podiatrist. We're trying to coach them to encourage to go get their eyes checked, to get back to the dentist, get to the other caregivers. If you have a CDE, the pharmacist coach can't do it all, especially medical nutrition therapy. That's a registered dietitian's realm. And once we go over the nutrition and they don't understand that whole process, they need that referral to go back and get that excellent education, especially if they're a train wreck and they're not understanding what's going on in weight loss, which goes along with the diabetes. These are some quotes from some of my favorite people. So, Asheville, it's the APHA Foundation, in conjunction with a lot of the pharmacy programs across the country, have collaborated with creating an evidence based on subsidized research. Again, it started with Asheville. We have multiple project impacts. Diabetes 10 City Challenge had the biggest impact, and at the same time, we developed medication therapy management. Here's the timeline. Can't leave out Pharmacy Times. Pharmacy Times did an excellent overview of all the stakeholders involved in getting the Asheville project together. It was truly a community program. I call it, if we all lived in Asheville, we'd have the perfect world. I mean, it's a great city, and John Miles did a great job down there, and so if you can get a copy of this, I know there's PDF copies of this. It'll give you some background as how this evolved. In Asheville, they were able to reduce their overall health costs, reduce sick days, and they improved behavior. You can see their A1Cs had a reduction. The patients that came into Asheville weren't up in the 8s and 9s in their A1Cs. They were in the high 7s, but they were able to get them down to 7.1, so they made a major impact. For Diabetes 10 City Challenge, those are the 10 city areas that you can see. We were able to make a substantial, about $1,079 per patient per year in reduced medical cost. We also showed improved presenteeism, which has been challenged because we need to repeat that again and show some presenteeism, because now we have some new tools to show what you're doing on the job. And so that's always in continued. These are the HEDIS results. We were able to improve the HEDIS indicators. And these are my Illinois results specifically. And so I like to show waist circumference, because when I'm talking to the CFOs and all the business people within an employer group, they don't really understand all of our medical vernacular. But when I say waist circumference, they can picture that, and that's something very valid. And now that we go into BMI, and in our population, we have plants all over the United States that have different diversified patients in there. So we have a high Asian population, and BMI doesn't work on measuring in the Asian population. So you need to look at the waist circumference on that. So we monitor waist circumference. On Project Impact, what made this a very different program for APHA's foundation grant was we did self-insured employers prior to that. We wanted to see if the model and the processes of care that we were employing with pharmacist-driven diabetes education would work in an indigent population. And so that was the process for that, and we just got some preliminary results. So as you can see, the A1Cs started up quite higher. So there were more train wrecks. These were people that had never had diabetes education in their life. They were employees that were migrant workers and didn't have a consistent health care and were coming into FQHCs. And so they were able to, in this first year, they were able to go from 9 to 8.3, which is a big deal in a population that doesn't get consistent drug therapy and see physicians or any team member on a regular basis. So we're making progress with that. Alongside, in parallel with all the diabetes research that we were doing, We worked outside of our silo with developing medication therapy management. Medication therapy management isn't any different from what I was doing in 1976 when I entered pharmacy school. Pharmacy just keeps changing the name of what we do. Sometimes it's pharmaceutical care, sometimes it's drug regimen review, sometimes it's drug utilization review, sometimes it's counter detailing. You know, we just keep changing the names up. Now we have all the silos and all the stakeholders have decided pharmacists are good at medication therapy management. And within medication therapy management, we're doing the medication review and helping them keep a personal medical record and doing an action plan and that med reconciliation that's so important when we throw over onto the Medicare side. On the Medicare side, we've been able to have CPT codes under the Medicare Part D that allows us to come in and help bill it. This is a big deal for pharmacy because technically there's only New Mexico, North Carolina, and California are the only 3 states that recognize pharmacists as providers so that you can bill third-party payers. So while we've been churning along for 150,000 years, we were neglected to be acknowledged for our cognitive abilities in practice, but only for our counting poor and stick and licking. So I haven't dispensed a pill since I work relief. Every now and then I work relief for the guys when they all want to go play golf or go hunting. And so they all call me up and I go work relief, and then I'm in a dispensing. I love it. It brings the patients to me, so that I still enjoy that process. But more pharmacists are more involved in direct patient care. So this is how we collaborate with you. So in your health promotion and your health risk assessments, and especially in helping advocate for immunization and wellness programs, in our health management, we can help you with those asthma, cardiovascular disease, coagulation disorders, congestive heart failure, depression, diabetes, and osteoporosis. And that's all underneath that big arm and umbrella of medication therapy management. And as you go through the measures, and as you start seeing the new measures we are developing, I am a member of the Endocrine Steering Committee for National Quality Forum. As you see this, more and more medication adherence measures are going to come out, because as the guidelines float and there aren't strict numbers for us to set goals on, they're going to start measuring, okay, are people on diabetes medications? Are the people with diabetes on a statin? That's the measure. That's where the measures are going. And your pharmacists, your local pharmacists in your community can assist you with that process. Just this week here in New Jersey, the Harvard Law School released a report that recommends to pay pharmacists for services in diabetes care teams. What's very neat about this is that New Jersey Medicaid is going to implement this. So this is another piece of evidence that helps show that we can be part of your team to help you make your numbers better for your own patients, and we're going to get paid for it. Payment is the big deal. Surgeon General did an excellent report about working with pharmacists. Then we held a collaborative practice policy with the American Public Health Association and CDC, and then the consortium got together. And on the CDC, there are toolkits and resources on how to create a collaborative care relationship. Because of the way the relationship that we don't have provider status, we work under the auspices of a physician, just like the rest of the medical team does. But sometimes we always don't know how to write those standing orders or collaborative care agreements so that it's a win-win for everybody. In some states, you can't call it collaborative care because that's a specific legal term for the doc and the PA and the nurse practitioner. So I'm trying to encourage pharmacists not to get their hair out of order when we say standing order. It's still the same relationship between the doc and the pharmacist and the nurses, and that's what we want. We want to be able to work together and be the medical home model for the patient. More reinforcement of the compelling evidence. I couldn't just be an APHA groupie, so I wanted to point out how Marie Smith has done great things in doing the research and publishing in Health Affairs about how pharmacists belong in the medical home. Then we have a meta-analysis done by Cheatham and Burns, and you know, she was a student when I was doing my fellowship, so I'm feeling really old that this young lady has published this meta-analysis, but I'm proud of her. And then Marie Smith came back and did an excellent job and her team about the ACO. So these are not great references for you to make a case in your own programs in order to support that. And then we have another diabetes care on our impact on cardiovascular disease and done with a meta-analysis. What I learned on serving on the NQF is if you don't have a systematic meta-analysis, the measure's not gonna get looked at. In summary, we have evidence that show that pharmacists' involvement in health management improves outcomes. Pharmacists are uniquely positioned to play a role in management and part of your MTM team, and we can help you with healthcare reform in the ACA and your medical home. This is more of what I just said, and we want to help improve patient care, increase communication between and among patients and providers, and availability of those objective measures, and reduce total costs over care over time, and maximize medication use by working with you as a team member. Thank you.